Now, continuing on with our conversation after that very sobering feature by Eunice Omolo, Hope Infantry, looking at the case of HIV infections among the youth here in Kenya. Let me introduce my panel as we get this discussion started. To my immediate left is Victor Kariuki. He's a patient expert. Next to him is Dr. Peter Cherutich. He's the head of Preventative and Promotive Services in the Ministry of Health. We also have Dr. Christine Sadia. She's a public health specialist involved in global health policy making and the chair of the Kenya Medical Women's Association. And last but not least is Joab Khasewa, who is the program officer for HIV prevention at the National AIDS Control Council. Thank you all for joining me. Let me begin with you, Dr. Sadia, because you've interacted with this for decades, if you will. And this is such a boggling thought of how many HIV infections there are among our youth and why the numbers are not decreasing, especially when it comes to AIDS-related deaths among our young people. What are some of the contributing factors? We saw some come out in the feature by Eunice Omolo when it came to some young people not wanting to take their ARVs due to stigma or cultural myths out there, some who fear pregnancy over contracting an STI or STD. But from what you've seen, what are some of the contributing factors to these rising HIV infections?
Thank you very much. I think the issues of HIV infection among the adolescents, which is a group that we could categorize from even 10 to 24, is something that is increasingly in the last few years has become a global problem, and not only here in Kenya but everywhere. Yeah. But the contributing factors are so many. If you look at the issues that come, if you look at HIV prevention from behavioral point of view, you have structural issues and also you have biomedical. So in those facets, you find that a young person struggles with so many things. The mind is developing, they are looking for economic issues. You find that they are in spaces, the brain is working differently. Then that forms their behavior and the way they relate with the issues of HIV. One also is the issue of information that they process. How do they process the information? How is their individual behavior vis-a-vis the environment under which they are operating? So if I look at it broadly without us narrowing, and the experts are here to narrow down on what are the critical issues in Kenya, for me broadly as a global advisor, I would look at it in those facets. And those are the major challenges that confront the young people. You saw in that feature, for example, a female vis-a-vis a male, the way they process. In fact, the infection is more worrying right now as we speak about a female compared to male. Right.
And Dr. Cherutich, let me bring you in on this from the Ministry of Health. In terms of the infections that we're seeing, the HIV infections, are these contracted at birth or are they coming from lifestyle?
Thank you, Victoria, for the invitation. So we have sort of a mixed picture. Amongst the younger adolescents, 10 to 14, the higher proportion is basically those young people who got the infection from birth. But as you go to the age of 15 to 24, it's mainly through sexual transmission, so through sexual behavior. Of course, I mean, it's a big concern, whether you get it from mother to child or from sexual behavior. The concerns are similar because these are people who are growing. They will have to deal with issues of self-esteem, as they grow up knowing that they have HIV infection. Their families will have to, put in a lot of time and effort and resources to take care of them really for a lifetime, and it's really a burden. And also for them, and particularly for young girls and young women, again, they're growing up, they will get into relationships, into marriage. They would worry about, how to relate with their spouse. They worry about maybe transmitting HIV to their spouses or to their children. So it's a big burden at the individual level, at the society level, and that's why we are talking about these things now.
Let's talk about prevention, and Victor, let me bring you in here because you interact with many young people as a patient expert. And we heard one of the individuals in the feature saying that the prevention message is just not getting through to these young people. And why is that, at least from your interactions?
Okay, if the message is, we say knowledge is power, and if you don't have information, then it's your ignorance.
Right.
We've tried as the National AIDS Control Council, we've done our best to give all the prevention messages we can have, and that the young people can understand. Yes.
And Joab, I mean, you also work with the National AIDS Control Council in terms of some of the measures being put in place. How effective are they? There's so many that have been tried and tested, but which ones have been effective and which ones have not over time?
Thank you very much, Victoria. Our first intervention that we are using is engaging the young people themselves, and that's why we have them here. Because there's nothing for them without them. And we are involving them first to design messages that are appealing to them. Recently we had International Condom Day, and condom has proved to be effective in HIV prevention with over 90% effectiveness. So the message we had is condomize was compromise. That's a message they designed, just to ensure that young people are able to access condoms to prevent HIV. And for us as NAC, we know that only 58% of young people are the ones who have correct information. Our target is these 42 who don't have correct information. So once we ensure that they have correct information on how to prevent HIV, starting with abstinence, condom use, then we are sure that we can reverse that trend of new HIV infections.
You mentioned the use of condoms to be very effective. However, we saw one of the other individuals in the feature saying that you'll find uptake of the morning after pill is higher than condoms. So what do you make of that kind of comment?
Thank you very much. So we are trying to address that.
Yeah. And
one effective way we are doing that is to try to address myths and misconceptions around condom use, because there are barriers or cultural issues which we are addressing, and especially by engaging the target populations themselves. I'll refer again to the International Condom Day. What we did is for young people to come up with games which they called Condolympics. The aim of those games was just to address those myths, make it appealing to other young people, engage the other young people during the International Condom Day, so that those myths, misconceptions around condoms are addressed to increase uptake. And it was very surprising, like the national event we had in Nakuru, over 250,000, 250,000 condoms were distributed. And it was not only disputing, there was also condom demonstration, so that when people take the condoms, they are able to use them correctly and consistently to prevent new HIV infections.
And let's still stay on this topic of prevention, because we heard, and Dr. Sadia, we heard Dr. Gitai from AMREF say that the old message used to be abstinence, be faithful, if not, use a condom. And with time, that has changed. Why? Why have we seen that shift?
For me, where I sit, I think we need to be evidence-based in terms of prevention. We are trying, we are actually, it's like we are doing experiments. So that message, as much as I would like to take it, is it working? I would like to go to, again, another sobering experience to tell you that condom use will start at a very high level without the girls even knowing the partners that they have. They drop immediately, and it's 90% of the girls that will not use the condom. So is the condom working? Because then in that circumstances, they are not working. So it's a tool that people then start using when they've not known you. When familiarity sets in, before I even know your HIV status, it's only 10% using condom. What does it say to our prevention measures? It is not working. What is evidence-based? What works for us? And I think we need to get back to the drawing board. That message for me, in that order, sometimes is not. We need to get the right mix.
And Dr. Cherutich, in terms of response, let's look at some scenarios here. In the urban areas, we're seeing many cases of women getting HIV infections from cross-generational sex.
Right.
In the rural areas, it's early marriage that's leading to this. So how are we trying to target these groups in these two different, very different areas?
Absolutely. And I think, Victoria, one very defining thing that cuts across is access to education. And, and it's good to talk about condoms, about all these things, but as Christine said, these are young people, they may not really have the capacity, you know, in terms of their thinking and their reasoning, to be able to maximize the opportunities they have for prevention. As it is, we have many interventions.
Yeah.
So to me, I really believe one of the biggest investments we can make as a country is to keep girls, particularly girls, in school. The more we keep them in school, schools are very safe spaces. They are places where they can get information and education. And then as they grow up, they get an opportunity to mature. Because usually for a girl, by the time they reach 21, 23, 24, they are fairly independent. They can make their decisions. They can make a decision to use condoms, to you know, have a meaningful interaction with other people. So regardless as to whether they can make decisions not to get married early, they can make decisions not to have intergenerational sex. Of all the things we talk about, I think we need to focus on keeping girls in school in particular.
Yeah. And Victor, I mean, when you've interacted with many young people, we heard a young person in the feature saying that the information is there, but many are ignorant. And then some of the panelists here are saying they don't know how to process the information that they are getting. What are you seeing it more of a case of it being?
Sorry?
What do you make of it in terms of it being too much information out there and they're just totally ignorant, or they're completely ignoring what is out there in terms of knowing how to protect themselves from HIV infections?
HIV, for now, the messages that are out there, it's that, okay, HIV, it's not a killer disease, it's not a death sentence, which is true. And some of the young people are now taking that for granted and saying, okay, I'd rather not use like you said, I'd rather not use a condom, and I'd rather have HIV, sorry, I'd rather have HIV than get pregnant, of which now that is the different messages that they get. And once if I hear my fellow peers saying that, oh, by the way, using a condom, it's like eating a wrapped sweet, which is you're eating nothing. I will definitely hear what my fellow peer will advise me, but not from the messages I get out here. Yes.
So how are you helping to counter a lot of those thoughts and try to break a lot of those perceptions when it comes to HIV?
For the condoms, the World International Condoms Day, there was, as Joab said, there were the games and the sorry.
It's all right, take your time.
The demonstration,
yeah, and
messages about the myths and the misconception,
yeah.
And we are trying as best to have at least little plays, yeah, about how misconception are not true. Yeah.
All right. Now, Joab, when it comes to treatment coverage and retention levels, where are we in terms of that here in Kenya?
The country has made progress, and we can say over 70% are on treatment, which is good progress. But as a country, we're now implementing test and treat,
okay,
which anybody who turns positive, irrespective of their CD4 count, should be put on treatment, because treatment is also prevention. It's also prevention intervention. And just to add on what Victor is saying, we are also trying to ensure information for young people reaches them in the most appealing way. Like for them, one is through the use of social media. Like for them, they have really maximized the use of social media. That's where you can find young people. In addition to that, during such occasions like International Condom Day, we engage some of their popular artists whom we give the message, which now the young people, since they appeal to the young people, they can pass that information to them.
All right, Dr. Sadia, where are we in terms of the funding environment? Money is needed and necessary to ensure that a lot of the efforts are effective and making a difference. So when it comes to funding, because there have been arguments that it's been decreasing over time, but where are we and how much do we need to ensure that these programs are effective?
Thank you. About the funding, globally, the funding is decreasing. Mm-hmm. But for Kenya, for a long time, we have had a bit of the global fund support, which I tend to think even last year when the proposal was done, I think we were successful in getting approval of the global fund. So we should be able to get that. But coming back to sources of funding, I think the domestic funding is an issue.
Yeah.
We are more reliant on external funding for a program that is really killing people and depleting the workforce of this nation. It is high time that even places where industries where people are investing begin to put a fund, for example. What are the best practices? For example, if you look at Botswana, South Africa, do we have a fund that people put in to increase domestic funding? Yeah. I think we need to really come back to our senses and say external funding is not going to be sustainable for this long haul that we are in. And as it is decreasing, also when the governments change, like for example the policies in the US is changing, so it's going to affect us. So I guess the realism is that we need to take the driver's seats with HIV, even in terms of some of the things that we say test and treat. Test and treat in this environment. Have we scanned the environment? What does it mean to some Kenyans? Because everywhere the behavior is different, and the people have their own cultures, whether they will assimilate it. I think we need to sort of like not jump, holistically, do some kind of piloting and say whether it works. And if it works, then we adopt it wholesale. So I guess it is an issue of programming, and I want to say, I think we have not gotten our programming right.
All right, you wanted to
just
add to that? Yeah.
I think the landscape is changing. It's improving, particularly on domestic funding, because over the last few years, government has put in substantial resources into HIV, about 2 billion shillings a year. And of course, there's also the promise of universal health coverage. So we do anticipate that the moment we've rolled out universal health coverage, it will take on some of this support that we've been getting from donors. So I think we'd like to urge people who are implementing these programs to really scale up universal health coverage, because it will in a big way really support domestic funding.
All right, and as we wrap up, I'd like to get your take on how we can improve the integration of health and community systems to address this as well.
Oh yeah, I think as government we're already doing that.
Yeah.
In fact, our National AIDS Control Council has a lot of engagement with communities. We have a program now in the counties of Kisumu, Homa Bay, Migori, and Siaya, called Dreams, which is trying to really work with communities and work with young people to build their resilience, to build their determination, and to create safe spaces. This is a community level project that is implemented, yes, by the Ministry of Health, but is really a community based. That is one of the best examples where we believe that we're actually engaging with the communities, and we will continue to scale that up.
All right, thank you so much. That's all the time we have. Victor, Dr. Cherutich, Dr. Sadia, and Joab, thank you so much. And certainly a conversation that we have to keep going in our living rooms, in our schools, in our churches, in our mosques.